Hello, everyone. Thank you for joining today. I'm excited to introduce this session, which is our special format of Teaching Point Recap VMR. So it's not our usual VMR format, but it's a session where we get to rethink old VMRs that we had. We always have amazing presenters who prepared a presentation to teach us about what they took away and what we can learn from thinking again about previous sessions in these VMRs. And my name is Leah. For those of you who don't know me, I will be kind of facilitating the session, but our main players and presenters today will be Kushal and he. I'm really excited for them to introduce themselves as well to you. And I'll start with Kushal. Kushal, if you want to go ahead, present yourself, tell us who you are, what you like to do, and then also feel free to go ahead and share the screen and start your presentation.
Thanks a lot, Leah, for the wonderful presentation. Hi, everyone. Good morning, afternoon, and evening. And I'm Kuchlamba Lagadi. Feel free to call me Kuchal. And one of my favorite one-liners over this past year has been One Life, So Many Dreams by Dr. Rafa. For those of you who don't know him, he's been a cornerstone for the formation of CP Solvers Academy itself. And in the next couple of days, we're going to be having a special VMR in remembrance of him. And I'm very grateful to be part of the academy as well as contribute to different activities to make one of his dreams at least come true. And with that, I'm going to share my screen for today's session. So I'm okay. So it's going to be about clinical approach to shortness of breath as well as hypertension in young. Why did I choose this topic? You might be wondering that. And the reason being that this month, most of the cohort of our cases were having shortness of breath. On 5/9, the patient presented was complaining of fatigue as well as progressive shortness of breath. On 5/15, the chief complaint was dyspnea and orthopnea. And 5/16, the chief complaint was worsening of shortness of breath over the week. And 5/20, the case I'm going to be presenting today largely is she was a 19-year-old female complaining of shortness of breath as well as dry cough. And the case presenter initially was Dr. Molinsha, and the discussant was none other than Dr. Michelle Pilson. And on 5/22nd, the chief complaint again was shortness of breath, and 5/23rd, it was dyspnea and an episode of LOC. So in our patient, she was a 19-year-old female who came with no significant past medical history. And for past several months, what she had was a headache, especially in the frontal area, associated with visual changes as well as tinnitus. In the past 2 months, she initially had shortness of breath and dry cough, and decreased appetite, exertional fatigue, weight loss, and nocturia. And her PCP had diagnosed her to have a community-acquired pneumonia, presumed, and started her on treatment, and she had no symptom relief, so she came back again with the same complaints of shortness of breath and dry cough. But this time, her vitals was tachycardic, and her heart rate was 102, her JVP was 12 centimeters, her BP was 172/106. And she also, significant finding was she had decreased breath sounds in her lung bass and crackles. And what Dr. Ms. Kilson was telling us was that it's the most important thing whenever a patient presents with shortness of breath is to start asking the most important questions or the crucial questions to elicit the diagnosis and to also start forming a differential diagnosis based on either etiology or pathophysiology. And I like referring to the dyspnea pyramid. The picture is actually available. The flow chart is available on our website, cpsolvers.com. And the first thing is that you want to rule out if it's a pulmonary cause. And in pulmonary cause, we want to rule out, if I'm going too fast, please do let me know. And in the pulmonary cause, we want to rule out if it's due to airway reason, which could be either asthma or COPD, or it could be because of pneumonia, or it's the alveolar region, or the parenchymal issue could be because of interstitial lung disease, or the vascular can be because of pulmonary embolism, or the pneumothorax. And diaphragmatic weakness. So how are we going to elicit this is to ask the important questions. Do any of you want to try as to what are the questions that you're going to be asking if the patient to elicit this diagnosis? And feel free to list them on the chat. And meanwhile, I'm also going to tell you what are the important questions which we will have to go through to find out further about dyspnea. One is when it started and for how long they've been having it, and has it become worse or is it just the same? And when do they have the dyspnea, like when they're doing any specific exertional dyspnea, or the number of flight of stairs they need to climb before they get dyspneic, or when they how many steps they have to take, and a 6 minutes walk is another thing which we do to find out further, get the diagnosis, and also to see if they are dyspneic at rest, when it disturbs their sleep, and if they're dyspneic when they're sitting down, they feel better when they lie down, or the other way down, when they get dyspneic when they're lying down, and so they would have to sit up. And one specific condition which the patient, it would be like a 5 years old or 4 years old child, when the mother says that when they're running, they start feeling very dyspneic and they squat. And that's to rule out congenital heart disease. And if any one of you want to guess where that's going to be very characteristic in the chat, feel free to do so. And they are so also to get the associated symptoms, like either are they having cough with expectoration, fever, those are all the features, or if they're having, or they're on OCPs, if they had a long ride in the flight, for instance, and obese lady with a smoking history who's on OCP with a long flight, they're very high risk for pulmonary embolism, and that could be a reason why they're presenting with dyspnea. So once you rule out pulmonary causes, then you want to start seeing if it's cardiac cause, if it's either acute coronary syndrome or arrhythmias or congestive heart failure. So then once you rule out also the cardiac causes, you've got to start thinking of other things. Like Dr. Ravi were mentioning that there was this one lady who presented with a hemoglobin of 3.8, and initially she was asymptomatic, and then she had dyspnea or shortness of breath is what she presented with. And that's anemia. The cause of anemia, anemia is also one of the causes why the patients can be presenting with dyspnea, or it could be because of neuromuscular weakness. Initially, they start off that day being all healthy and happy and nice, but through the day progresses, so with increased activity, they become weak when they start having drooping of their eyelids and also dyspneic. You want to rule out if it's either myasthenia gravis. And anxiety or panic attacks can also be a reason why people are presenting with dyspnea, or the other thing can be because of acidosis. So for instance, if a person was caught in their garage with, they started their, if any of you have seen this movie called Man Called Ove, I think, I forget, I'm pronouncing the name. It's about Frederick. Yeah, so the movie where he actually tries committing suicide, being in the garage and having his car start turned on, then they can actually have dyspneic, or can be because of acidosis, and then they could be dyspneic. So the other complaint, or the chief complaint this patient specific had, was not complaint as much as the finding which we had was hypertension. Her BP was 170/100, which is both systolic as well as diastolic. And she's less than 40 years old, so we would call her as hypertension in young. And the most important thing is to rule out medication. If it's because of any medicines she's taking, either OCP, steroids, or weight loss stimulants, or if she's on any antidepressants or antipsychotics. And the next thing, which once we rule out if it's not because of medications, we would actually, there's a prevalence of secondary hypertension in young people who are less than 40 years old is about 30%. So that's a large percentage, and we would want to be mindful of that. And to be able to elicit a differential diagnosis, again, it's important to ask the crucial questions. What would be the questions is if they're having any associated symptoms like headache, our patient had that, and any leg swelling, chest pain, stress, and sleep disturbances, snoring, and any darkening of their skin, increased tanning, facial morphology has changed. If their wedding ring is not fitting them anymore, they would have to go through different sizes of their footwear very rapidly, and caffeine intake, the number of coffee they drink per day, or if they're having any excessive bleeding in their stool, or if they're on drugs. So when I was doing an OBG rotation, actually 2 cases, Once was a mother who was accompanying the girl who was pregnant, who was in term pregnancy. She was about 30. The mother was 36 years old, and who looked very gigantic, and her facial features was very coarse, and she was very hyperstimulant. And after we consoled her about saying her daughter's going to be having a safe pregnancy, then we also tried finding out if she was having these coarse features always, or if it's something which occurred suddenly. And she said it was over the past 2 years, her features became very coarse, her nose became very big, and her wedding ring wasn't fitting her anymore. And actually, people in her village had outcasted her, saying that she's possessed by a devil. But then we did all the tests which was required, and we found out she was actually having acromegaly because of a pituitary tumor. And we did treat her for that, and also started giving her a cabergoline, and then she underwent a transperineal hypophysectomy for it. So that's like an acromegaly can be a cause also for the hypertension, and her BP was very high. Another patient whom I did really see was this lady who had come, who was again 19 years old, but she had come because she had not yet got her menarche, and she had a familial history of everyone having delayed puberty in her family. So they were very careless, and they came only when she turned 19. But she had this wet neck and also her low set ears. And she's short even for and lower than the Indian average women height. So we actually started taking her salivary the swab, and then we did, and she turned out to have Turner syndrome, and she did have a coagulation of aorta, and hypertension was present even in her. So those are the things which we do not want to miss out on, because they're common with 30% prevalence in people who are less than 40. So in our patient, she was again, so we want to we have this chart in our website, and it just like it's a systematic representation of what I spoke so far. The other thing is important is to differentiate whether it's acute hypertension or acute or chronic hypertension. So for acute hypertension, it could be because of also urinary retention or constipation, fracture, something which we don't want to miss out on, or it could be because of pheochromocytoma or dissection of the aorta or hematoma. Those are things which we don't really want to miss out on. So for this lady who was 19 years old, female, with no past medical history, complaining of shortness of breath as well as cough, her significant labs was her ESR and CRP was elevated, and BNP was very high, 2734, and her aldosterone and renin ratio was slightly low. What does this mean? It just means that the renin is a little lower compared to the amount of aldosterone which is being produced. So her AM cortisol was supportive of it, also being 581, which is very high. So Dr. Gilson was mentioning how this is a high time when also an endocrinologist is included in the team, because we need to start seeing if it's due to Cushing syndrome. In this patient, the echo showed an ejection fraction of 15%, a global hypokinesia, and multiple apical neural thrombi, and IBC was dilated. The MRA of the chest, this magnetic resonance angiography, that showed a mild enhancement of the mid-abdominal aorta and the proximal renal arteries. And there was a mild diffuse mural thickening of the distal arch through the abdominal aorta, and stenosis of the renal arteries and distal thoracic aorta, as well as the origin of the superior mesenteric artery. So with these findings, the team, so problem representation for this our patient was 19 years old female with no past medical history, presented with 2 months complaint of shortness of breath, dry cough, along with headache, joint pain, weight loss. On examination, she was hypertensive, tachycardic. Her lab showed heart failure with reduced ejection fraction, and I'm going to go into detail why that's important. And an MRA indicative of diffuse neural thickening of distal arch through the abdominal aorta, including the SMA as well as renal artery. So, like I mentioned before, people who are young, they have a very high tendency to compensate for any pathology which is happening or within their body. So if they're having a heart failure, how do we find out if it's actually due to an acute cause or underlying chronic pathology is happening? So if they're presenting with heart failure with preserved ejection fraction, then we know that what they're having is actually an hyperacute heart failure. But like in our patient, it's reduced ejection fraction, which just shows that she's having an underlying pathology, and we just don't want to miss out on that. And her MRA findings were also supportive of the fact that there was neural thickening of the arch as well as abdominal aorta, superior mesenteric artery, and renal artery. And with that, the team had made the diagnosis of renal artery stenosis. And the most common cause of renal artery stenosis in total is atherosclerosis of the vessel, and it's usually common in adults. But if it's younger people and if it's women, and the most common cause is actually fibromuscular dysplasia, which is 10 to 20% of the renal artery stenosis are because of that. But in our patient, it was because of Takayasu arteritis. And what's the pathophysiology of renal artery stenosis? Basically, there's increased renin secretion, which is actually causing increased aldosterone secretion from the adrenal cortex. And that causes sodium retention and water retention and loss of potassium. And also and then there's a high blood pressure, which is happening because of this water retention and sodium. And that causes the damage of oxidative stress, vascular remodeling, and damage of the DNA. And the also stiffening of the arteries are occurring because of high blood pressure, and that can cause atherosclerosis, and that can be the reason why there could be proteinuria, chronic renal failure. It has effects on various organs, including the heart, which can have the left ventricular hypertrophic congestive heart failure. And if the coronary vessels are themselves involved, it could be causing acute coronary syndrome, ischemia, or cardiac fibrosis. So as Leah was asking in the chat, why there was dry cough, it could be because of our cardiac symptoms itself could be causing that. And also because her base in the lung, bilateral lung base was actually, she had crackles and decreased breath sound. It could be all because of that, because she was having a dry cough. So in our case, so the Takayasu arteritis is something which is more common in women of Asian descent, and is more common in women, like 5 times more common in women than men. And the incidence is 1 per million. And it's a pulseless arteritis. It's known as also the chronic non-specific granulomatous vasculitis affecting medium as well as the large vessels. Usually the patients present with either constitutional symptoms, neurologic symptoms, depending on which organ is affected by the arterial stiffening and atherosclerosis, and gut malperfusion, like if the superior mesenteric artery in our patient was thickened, so that could be the reason why she could have a gut malperfusion, as well as intermittent claudication could be another presentation. So the criteria to diagnose Takayasu arteritis, there are multiple criteria and various, and it's evolving. The one which is most commonly is used, the ACR criteria, but at least the patient should meet at least 3 out of the 6 criteria. The age should be less than 40. They should have symptoms of claudication in extremities, decreased brachial artery pulse, and blood pressure difference in both the limbs should be more than 10 mmHg, and they should have a Bruni and arteriogram abnormality. And our patient did have 3 out of the 6 criteria. And the most important differential diagnosis for Takayasu arteritis is what's known as giant cell arteritis, which is more commonly present in people who are more than 50 years old. And on pathognomonic finding is that it's going to be affecting the external carotid artery and its branches. And so for the evaluation of the Takayasu arteritis, like the severity or classification,
I think we might have lost the connection to Kushal, unfortunately. We'll see. We'll see if Ayashi just joined again. In the meantime,
I'm so
feel
sorry.
Kushal, you're back. Perfect.
Yeah. Okay.
Okay, then continue.
So Yeah, so there are different scores to identify the severity. One is known as Takayasu arteritis damage score, which includes various factors such as age of onset, duration of symptoms, and cumulative steroid dose, which is required for the patient. The other score, which is most commonly used, is known as vascular damage index score, which evaluates the treatment-related damage to various organs. So in a case of severe Takayasu arteritis, it's called as very severe because the patient present with either organ or life-threatening disease such as stroke, heart ischemia, and limb ischemia. So the biopsy of the vessel is going to be the gold standard for diagnosis of any vasculitis. And in case of Takayasu arteritis, the stains usually used is either hematoxylin stain or BBG stain, which is a Burghardt Van Giesen stain. So like you would all remember, vessels have three layers, the intima, media, as well as adventitia. So in Takayasu arteritis, there are changes in all the three layers. What's happening to the adventitia is that's going to be prominent fibrosis. And in media, there's outer media and inner media. In Takayasu, the outer is affected more than inner, and there's going to be extensive destruction of the media itself. And the intimum layer, again, because of arterial remodeling, oxidative stress, as well as DNA damage, there's going to be intimal thickening, which is happening. In Takayasu arteritis, the mainstay of treatment of the disease is high-dose steroids given in pulse, or glucocorticoid sparing agents like methotrexate, leflunomide, mycophenolate, mofetil. But because of bilateral renal artery stenosis our patients having, or they're having any arterial disease, aorta disease, the aortic repair surgery is common. And Dr. Kittleson was mentioning how they might be requiring multiple or repeated surgeries rather, because it's a progressive disease, and it's not like a glucocorticoid just suppresses the inflammation, but it doesn't really stop the disease process itself. So this brings me to the end of my presentation, and for preparing this whole I'm still learning a lot about hypertension, but at this point, these are a couple of resources I've gone through, which is the approach of dyspnea as well as cardiology grand rounds from the University of Washington, and American College of Rheumatology website, and then Takayasu arteritis workup, which is there in Medscape, and any GM article, as well as the Takayasu arteritis treatment guidelines by the Vasculitis Foundation. And on our website, the schema episode 250 goes in detail about how to diagnose patient presenting with dyspnea as well as hypertension, which would be in a great resource as well. Thank you so much.
Thank you so much, Kushal. This was really comprehensive, really well done. And just to remind us what we covered, like we talked about the case, kind of a recap. We talked about shortness of breath, a really basic, important chief complaint. Then we touched on hypertension in the young, which I would think is also super interesting. And then we had kind of a masterclass on Takayasu arteritis and how to approach that. So thank you very much. There was much in here. Are there any questions or comments? Feel free to share them in the chat. And just, yeah, share them here. If there's no acute question at the moment, feel free to ask it later as well. Then I would go ahead and we can proceed with the next presentation, which is E. Thank you so much for being here today, preparing a presentation. Do you want to introduce yourself, and then you can go ahead and share your screen?
Yes. Hi, my name is Hee Moon. I'm a IMG from Korea. It's really honor to present the case, and my hobby is dancing. I love dancing, tango, salsa. So that's how I release my stress. Okay, I'm going to start my presentation. Okay, can you see it? Okay, great. Okay, so I'm going to present a Sawson case. It was on May 16th. And case discussion were Robbie and Tansu. Okay, so the patient was, oops. Okay. Oops, sorry. How I'm going to, okay, sorry. Start. Okay. Okay, so the patient was a 56-year-old male with a cirrhosis, a past medical history of hepatitis C, symptom were dyspnea on exertion and also at rest. Sustan did a physical exam and improves when lying down and no peripheral edema. Vital signs were febrile, tachypnea, and SpA02 was 88% on room air and 91% on 100% oxygen. No significant improvement with the oxygen. So we consider about shunt. Physical finding was typical signs of cirrhosis, jaundice, gynecomastia, and loss of body hair. So we discussed about the cause of dyspnea in cirrhosis, parenchyma like pneumonia, risk increased by hepatic encephalopathy, risk of aspiration, and immune dysfunction. And diaphragm will be like hepatic hydrothorax above diaphragm and ascites below, because ascites can penetrate through the defect in diaphragm, also lymphatic channel, and liver cirrhosis has a low albumin, so it can also cause the low albumin and oncotic pressure decrease, so hepatic hydrothorax can happen. And vascularly, like hepatopulmonary syndrome, vascular dilation, portal hypertension, and non-pulmonary edema due to GI bleed or nutrition deficiency, iron B12, B6, folate, like alcoholic drinker, right? And hypersplenism or hepatitis and toxic effect on bone marrow can cause anemia. So we consider about that too. And also the oxygen didn't improve. So one of the shunt, intracardiac shunt, PFO was another thing to consider. And recommend test was CBC, CMP, ABC. Chest X-ray will show like hepatic hydrothorax, and high resolution CT will to assess for parenchymal disease or pulmonary vascular dilation or pulmonary AV malformation. And TTT with bubble study is to detect the shunts. Test result show mild anemia and thrombocytopenia. Thrombocytopenia can occur also because of hypersplenism. And ABG showed pH 748, PaCO2 31, PaO2 63, which I calculated, and it shows like 48, and a wide AA gradient. And high resolution CT, Sawson said there was a shunting with a communication with the right lower lobe, indicating some dilated peripheral pulmonary vessel, and bubble study delayed appearance of a bubble in the left atrium, indicating intrapulmonary shunt. So and there is a learning objective that I want you guys to totally understand from this case is number one, what are the physiological response of the lung to hypoxia? And number two, how do intrapulmonary vascular dilation cause hypoxemia in hepatopulmonary syndrome? Number three, why does lying down improve dyspnea in patients with HPS? Number four, how does microbubble contrast echocardiography work, and how does it distinguish between PFO and intrapulmonary shunt? Okay, all right, and okay, so when you have a response to like hypoxia, how does our organ is working? Maybe you can put on the chat, like kidney and brain, how does it work, and lung. Yeah, so let's oh, okay, so I'm sorry, I just passed it. Okay, sorry. Okay, so kidney and a brain will be vasodilated, right? Because we need blood, precious blood as soon as possible. But lung is being a little bit smart because hypoxic pulmonary vasoconstriction, which we have to use our precious blood in a like ventilate area, not fully ventilate. We don't want to waste our blood, so we redirect blood flow from poorly ventilated area to well-ventilated area of the lung, optimizing gas exchange, right? But what's the problem with the hepatopulmonary syndrome? When there is high pulmonary hypertension, what is causing it? Okay, so moment. Okay, so how the intrapulmonary vasculation dilation cause hypoxemia? Portal hypertension increase NO, right? Causing vasodilation. That's kind of counter effect of portal hypertension because splenic vasodilation and increased NO and causing vasodilation. And then sometimes liver injury like hepatitis or some toxin can cause increase of macrophage and increase TNF alpha, INOS, and increase NO. That's how we get a lot of increase of nitric oxide. So if you look at this, I'm not artist, but this is my drawing. So if you compare with the normal and vasodilated, like the vasodilation makes blood pass too quickly through dilated vessel, and if you see, it doesn't have time to exchange the gas. But here, normal alveolus is a small, like it's a normal size, so it has plenty of time to oxygenate blood. And also, if you look at the distance, it's vasodilated, right? Because diffusion impairment due to increased distance here, this part is not getting oxygenated. So because of the speed and the distance, the vasodilated alveolus is not getting enough oxygen, okay? Right, and why does lying down improve hypoxia in patients with hepatopulmonary syndrome? Phlegmia is a shortness of breath when sitting up and relief when lying down. Although dyspnea is oxygen desaturation in the upright positions. So we diagnose POS, like SaO2 is dropped 5%, or PaO2 drops more than 5 millimeter Hg when upright. So the problem with the intrapulmonary dilation is that it mainly occurs at the lung base in the hepatopulmonary syndrome. So upright position increased blood from flow to the lung base. So it worsening the shunt because at the lung base, ineffective vasodilation is happening and you're giving more blood. It's not going to work, right? And supine position improved oxygenation by you redistributing blood from lung base to apex. So there will be no more vessel in apex and there will be a more redistributing blood and oxygenation will be better, okay? Okay, and then we are going to start with the bubble study with the TTE and echocardiogram. So how does it work? We make acetate saline, like we mix 9 milliliter normal saline with 1 milliliter with an empty syringe, and we push back, and then we make a micro bubble larger than 10 micromillimeter. So if you look at the pulmonary capillary vessel, it's a very tiny size. So it's not larger than 10. So in normal individual, microbubble, due to their larger size, they are trapped into the pulmonary capillary and do not pass into left atrium. So so you understand why it's not going to pass, right? And then microbubble inject into peripheral vein are visualized with the TTE. And so the patient had a high AA gradient, right? Without improvement with oxygen. So there is a shunt. So we use the echocardiogram with a microbubble to differentiate it intracardiac shunt, PFO, and pulmonary AVM. It's hereditary hemorrhagic telangiectasia is like epistaxis, telangiectasia, and AVM in hepatic and cerebral, and like, but pulmonary AVM is thin chesticity is gold standard. You can see it well. So hepatopulmonary syndrome is not really, you cannot see through the like chesticity. And Sulson case was very fortunate that she was able to see it, but usually hepatopulmonary syndrome gold standard diagnosis is TTE with a microbubble. Then my question was, okay, so even PFO, how can we overcome? Because usually left arterial pressure is higher than a right arterial pressure, right? So how can we overcome? Can you guys think about any maneuver that we can do? So I'm going to show you what kind of maneuver we can do. We can do Valsalva maneuver. Like if you force expression, like you hold your nose and close your mouth and like, like a defecation or blowing a balloon, like if you do force expression, what happens? The rib cage moves inward, diaphragm moves upward, abdominal muscle contract, and when the glottis is closed, air is trapped in the lung, and it increases intrathoracic pressure. So when you have increased intrathoracic pressure, it decreases venous return. So it decreases right heart and left heart both, right? But after releasing the strain, blood is ready to return to the right side of heart first, right side and then left, right? So at that moment, this results in a brief period where the right arterial pressure is higher than left arterial pressure. So if the Valsalva maneuver was successful, the arterial septum will bulge from right to left. So microbubbles can move to right to left. And then now the question is, how can we differentiate it? PFO, intracardiac shunt, and intrapulmonary shunt. So like that's the distance, right? Intracardiac shunt, bubble move from the right atrium to the left atrium, short distance. Microbubble appearing before the third cycle indicate intracardiac shunting. And intrapulmonary shunt, pulmonary vasodilation, microbubble move from the right atrium, right ventricle, pulmonary artery. Now pulmonary capillary is vasodilated, so microbubble can move. And pulmonary vein and left atrium. This process takes time. So, I mean, it's short time, but still it's longer than intracardiac shunt. So microbubble in the left atrium between 4th and 8th. So think about 4, okay? So if it is more than 4th and 8th cardiac cycle, it indicates intrapulmonary shunt. And if it is less than 4, it's intracardiac shunt of a PFO. Okay, and going back to our patient, diagnosis criteria for hepatopulmonary syndrome is portal hypertension has to be present, and intrapulmonary vascular dilation confirmed by TT with the bubble or radioactive lung perfusion scanning. So radio lung perfusion scanning, we can see the albumin like going through the brain because there is a shunt, right? But we cannot distinguish between PFO or intrapulmonary shunt in the lung perfusion. And also another criteria is hypoxemia. PaO2 has to be less than 80, and AA gradient has to be more than 15. I mean, if over 60, it has to be 20. And treatment is liver transplant is priority if PaO2 is less than 60, and the PaO2 is less than 40 issues for prognosis. So yeah, and this is my okay, and then this is my reference. Yeah. So Leah, the bubble is too big in normal person, it's stuck in the pulmonary vessel. It's not going to show up if it's no shunt.
Amazing. Thank you very much, He. This was a fantastic presentation. I think it's so interesting because I saw the case when on VMR, and it was not easy for me to understand. Like even like there's so much pathophysiology behind it, and some things you have heard of, some things I've never heard of, and then it's so cool that you just summarized it for us and brought it in this form of presentation. So thank you so much for taking the time and effort to prepare this and present this in such a nice, understandable way. And let's just also appreciate for the image, for the sketch that you draw that helped us to understand it better. Are there any questions or remarks in the chat? I don't see any new ones here. Yeah. In that case, we only have 2 presentations today. Normally it's 3. We had a last minute cancel because one of our presenters unfortunately had an acute illness, but we wish her a fast recovery and hope to see her healthy back again soon. In the meantime, I think we can end this session for now. Thank you again, Kushal and He, for taking the time for preparing this. I think this is also one of the aims of the format, that we get to take the time to actually think through cases that might be more complex and take time to like shine light on some smaller aspects of it. So really grateful for everybody who has been here showing up, and mostly for the presenters today. And I wish you a nice rest of your day and see you tomorrow, hopefully. Bye.